Hola, bienvenidos a esta sección del PreCongreso ICBA 2020. Y como pueden ver en el título, lo que vamos a hacer ahora es una entrevista con John Rumsfeld. Él es el jefe de innovación del American College of Cardiology. Lo hemos tenido físicamente el año pasado y este año lo tenemos obviamente por cuestiones obvias de manera virtual, pero va a ser un placer con nosotros charlar con él sobre la transformación digital en medicina, que es su principal foco dentro de la innovación en el American College. So, welcome, John. How are you?
I'm very good, and it's a pleasure to see you. I wish I was there as I was last year, maybe next year again, but also very nice to see you even virtually.
Thanks. Definitely, it would be nicer to have you here like last year and also eat a barbecue as we did. But hopefully next year this whole pandemic problem will be better and we can travel again and see each other. So, definitely. So it's been a year since we've been talking, and last year you talked about digital transformation in medicine. And I think that with this virus, with this pandemic problem that we are all suffering, some good things happened, and maybe those good things happened in your field, which is digital transformation in medicine. So what could you say that happened in these last 12 months since we saw each other, and what things were better because of the virus, because of the pandemic than the last year?
I think your point's a good one, which is we've had a vision, I know it's a shared vision that we've had together about when we talk about innovation and cardiovascular care. There's been so much innovation in the history of cardiology, from procedures to therapeutics to everything, but just not in the way we deliver care. We deliver it pretty much still in the walls of the hospital and the clinic, and we don't know what's happening with our patients in between time. And we know, though, that there's all this technology, emerging technology, the broad umbrella of digital health or digital technologies, but it's may have been really slow for it to make its way into routine care. And we can come back to some of those reasons, but as we talk. But this last unfortunate period of time with the pandemic has actually, to your point, served as an accelerant for a few pieces of digital transformation. When I say digital transformation, again, there's no widely specific or widely recognized definition, but in general, what I'm talking about is shifting our cardiovascular care to be more virtual, telehealth, etc., digital health or remote monitoring, so using wearable or non-wearable biosensors, voice technologies, optical technologies, and then the analytics you need to get information out of the data, so AI-driven care, artificial intelligence, analytics applied for imaging, risk prediction, diagnosis, etc. And across that spectrum, obviously the one that's had the biggest acceleration during COVID has been telehealth. In the United States, as back as you want to look, as many years to decades back, there's never been more than about 5% of outpatient visits done by telehealth in the United States. And in early March of 2020, it was still at 5% or less. And even then, that's only in pockets. By May of 2020, 70 to 90% of all outpatient visits in the United States were being conducted by telehealth, either audio or visual or both. So it proved that the technology is actually ready to be there and be adopted if we needed it to. It's unfortunate that we had to prove the point the way it was done, but the point was proven that telehealth can work. Unfortunately, however, and I'll hand it back to you. Unfortunately, however, that curve shot up with the COVID pandemic, and in the United States has come all the way back down to a pretty low level. In other words, some places have gone all the way back to no telehealth visits. Some are using 20 to 40% telehealth visits, which is higher than the historical baseline. But it's interesting that while it shot up during COVID, it's also gone back down. And I think that shows us that we can make strides in the world of digital transformation, but it also shows we have our work cut out for us.
Yeah, definitely. It's like it doesn't depend on the technology, but it depends more on the problems that drive those innovations. I mean, the virus was a problem that we had to approach, and in that case, we were very ready to use telehealth. But now that the problem is not so bad, maybe everything is returning to normal. But I think that related to virtual visits, it won't go back as we were last year. I mean, I suppose that it's gonna be not as high as in the middle of the pandemic, but it'll remain in a very high proportion or percentage of the whole ambulatory visits.
I think you're correct. I agree, and I think though that the need is on us for your practice, for my practice, for the American College of Cardiology, and for our collaboration. Where I really think we need to push the envelope is on the difference between telehealth, just basic telehealth, and actual virtual care. You use the phrase virtual care, and I think that's the phrase we need to adopt. Because I think that it's one thing to do what you and I are doing, which is audio-visual exchange or talking to each other. And that's better than nothing. When at the peak of the pandemic, being able to speak or see patients and their families in their home setting was helpful. But for example, most obvious examples, I think you were alluding to this, is we start to think about clinical conditions to actually manage virtually, and we immediately say, well, wait a minute, we're going to have to see them in person. Now, I think we'll always have a hybrid of in-person and virtual, but I think we can do much better on the virtual care. And what I mean by that is, if you have a patient with atrial fibrillation and you're doing a follow-up visit virtually, probably we need their vital signs. We need at least heart rate, blood pressure. Be nice, potentially, we can ask them about their symptoms, but what about heart rhythm? We should be able to have that and know what it is. If a patient's saying, I'm feeling a little more fatigued and short of breath, wouldn't you like to know what their heart rate is, and are they in or out of atrial fibrillation? And not just synchronous. There's a synchronous virtual care, which is during the video visit, but we also have to talk about asynchronous information, meaning between visits. And that's where we get into remote patient monitoring. We've always thought that we could do more with wearable and non-wearable biosensors and so forth, but they're not part of our routine care. We have to be careful about data overload. We need to just get the key information. I just like to know the heart rate trend. I just like to know what percentage of the time a patient's in or out of atrial fibrillation and their rate control. And then just apply that to other cases. Just simple blood pressure management. You need to know the blood pressure and what it's been in between visits. Heart failure is obviously an obvious one. If we're going to really manage patients virtually, either in whole or in part, we're going to need to know their symptoms, but also their volume status, their vital signs, etc. Especially if we're going to do things like optimize their guideline-directed medical therapy virtually, which I think we can and should do. But we got to show how to do virtual care before this is really going to work.
It's interesting that the telehealth, the video visits increased very much with the pandemic problem. But the patient monitoring aspect of digital transformation, it seems that it didn't grow as much as the video visits. It seems to me that that's a way of managing chronic patients or cardiovascular patients that still we are not using in a daily basis. And what do you think? Because I think that the technology is there, the problems, the patients are there, the problems that are not being solved, but the actual system are there. But even though all the ingredients are there and the pandemic is like speeding up everything, this, it seems to me, that didn't speed up. It's still so, I don't want to say sluggish, but very, very slowly advancing. the patient
I
monitoring.
completely agree. I completely agree that all the ingredients are there. The technology is absolutely there. It is getting more and more advanced, and we're not falling in love with the technology. You always fall in love with the problem you're trying to solve, not and then find the technology to solve it. I will say that because I have the pleasure of spending most of my time working with these emerging technologies and startup companies from all over the world, that the sensors that are coming along get more and more amazing. It'll make it easier and easier for both patients, their families, and us to use and get that information. But we still have plenty right now. So why aren't we using it? To your point, why is it sluggish? I think number one, there is just inertia from the way we were all trained. I mean, I was trained to do a clinic visit pretty much the same way. My room and clinic looks the same when I was a cardiology fellow as it does right now, and the way we bring in patients into the room and they come in for drive-in for their visits. We just haven't done it a different way, even though COVID
It's a
pushed us to do a little bit different.
patient
But
monitoring is a role that we've never done.
yeah,
I mean, video visits, we've been doing it in presence for decades or centuries, but patient monitoring at distance, it's something that we physicians have never done before. Maybe that's the reason.
yeah, so I think it's something new. So we have to, like I said to my earlier point about making it virtual care, not just a video visit, we have to show how to do, we have to show the way. What's the best way to do it? We also need to start training our future cardiologists and cardiovascular clinicians on, there should be actual curriculum and training on virtual care. We have to define it and do it right. There is a second bucket though that's important that you and I obviously know but need to articulate or say out loud, which is remote monitoring. Let's just take heart failure. The remote monitoring literature and evidence base for heart failure has not been great. It's been mixed, right? I think both the European and ACC/AHA guidelines say that the evidence has been mixed. They can do meta-analysis and show that remote monitoring for heart failure, when you add it all up, looks like it on average is effective. But I think that we still have our work cut out for us to prove the value of remote monitoring. I am very optimistic about this, or at least optimistic to try it. And what I think is an important point here is that we started out with remote monitoring being pretty low tech remote monitoring, meaning just symptom tracking, which is great, tracking your weight and see when somebody's heart failure patient weight goes up 3 or 5 pounds. I think it's pretty easy to argue that's too late, that the exacerbation has already started, the decompensation has already started. And what we need to do is push to the left on the physiologic monitoring. This isn't magic, by the way. This is just physiologic monitoring like we do in the hospital, but now applied at home through wearable and non-wearable biosensors. We still need to prove this, but I think we can get earlier physiologic signals. For example, sleep patterns disrupt a week or more before heart failure patients start to gain weight, before you have fluid retention to the point of gaining weight, and other monitoring of filling pressures. We talk about implantable things like cardiomems, but there are increasingly going to be non-invasive sensors for that. And when we're armed with that data remotely, I think we'll be more confident that we can see a patient is doing well. So we might want to up titrate their medicines to GDMT, guideline directed medical therapy, to optimize them. Or a patient's getting in trouble and we bring them in. But we don't always have to do everything in person. So the first point is a bit of inertia, but also just how do you do this well? How do you do virtual care, like you said? How do we do remote
The
monitoring?
implementation science.
Yeah, the implementation science is number one. Number two is build the evidence base. We need more evidence that this really is safe, effective, and will improve outcomes, improve the health and engagement of our patients and their families. And then in the United States, and I don't know if it's the same for you, but there is a third part that's really important, and that is the payment model, the incentives. In the U.S. system until COVID, we got paid. Couldn't get payment models for telehealth. Now that's changed, and that's a big change. They've actually made it, most of the payers in the United States, the insurance in the United States is now paying the same for a telehealth visit as an in-person visit, but only at sort of the lowest level of complexity. And so if you see a patient in clinic and you do more things, it's still in the US system a lower payment if you do it virtual. But I think that's changing. I've talked to several of the leaders of payers, large, very large payers, private payers in the US, and they are very interested in this idea of, well, if you're managing a heart failure patient, probably that should be a higher degree of difficulty, but we have to, and you can do the remote monitoring, and maybe we should align the payment. We have a ways to go on this. And as you know, the US health system is overly complex. It's overly expensive and has a lot of waste in it, but we're skating towards what we call more value-based payment models, where you're going to be incentivized to do remote monitoring and do virtual care more and more. I don't think it's crazy, even though it's been a long time coming here and in Argentina, around the globe. I won't be surprised if between 5 and 10 years from now that the majority of our care is done virtually, outpatient anyway.
Okay, great. One last question, because it's time to finish. Do you think that we physicians will have to pay attention to some things that we didn't pay attention before, not that we have the information? For example, as you said, the sleeping quality, or the activity, or even the tone of the voice. I mean, we will have some input, some information that we didn't have before, that maybe could be as important as blood pressure, maybe. And now that we will have, that it will be available, maybe we will have to pay attention to that in our daily basis. What do you think about that? And which could be those new aspects of the patient's characteristics or information that we are gathering with these devices, with these wearables, that we may have to embrace to improve the quality of care?
I think you're absolutely right. We are entering into an era, it won't be overnight, and it's not magical, it's math, but it's going to take, I'm going to say it's hard to, these predictions are always difficult, but over the next 5 to 10 years, a lot of the way we used to gather physiologic data is going to, I believe, shift to this remote monitoring, digital health tools. I'll come back to which ones I think are most promising in a minute, but I think I think most individual cardiovascular clinicians or cardiologists are excited about this, because who wouldn't want this being better, having more information of this from these emerging technologies? Cardiology is a high-tech field. At the same time, we have to immediately say that this can't be burdensome and it has to fit patients and their families, the technology, although we're seeing the fastest growing use of smartphones in patients, older patients. Second of all, we don't need data. We don't need data deluge. We're going to need to have the analytics. This is where artificial intelligence, or more simply put, machine learning, nothing magic again, just math, looking for patterns in the data so we know the information, like you see a trend line, not get overwhelmed with information. And I really think this can come through and make us better at what we do. This is, of course, just an opinion. I think sleep physiology is a window into overall health status. And if you're getting in trouble, say with heart failure or other things, it's going to show us earlier signals than we ever realized. I believe voice technologies, as you pointed out, as patients start to have heart failure exacerbation or just ill for other reasons, it shows up in the voice pattern. And then imaging. The best thing that artificial intelligence and machine learning does is pattern recognition, and so imaging is where it really does well. And you're going to see things beyond the human eye spectrum, where it's, for example, just comparing images, or even as we're speaking, having the images say whether what current health status and physiologic state is, and is it changing, and also interpretation of images. None of this is going to replace cardiovascular clinicians or cardiologists. It's going to make us more efficient, faster, and better at what we do. I think my daughter, if she decides to pursue medicine, she will use artificial intelligence, and she will be a better clinician than those who don't use it. And I think that's where we're skating. We do have to build the evidence base.
Okay, John, thank you very much for your time. It's always a pleasure to talk with you, and to just to see the near future of cardiology, how it's going to be. So thank you very much.
Thank you. It's a pleasure to see you, and I hope to see you in person next